So, just quickly, so Sally, that's you coming up next, is that correct? That's not on my agenda, so we might stick to the agenda. Just an anecdote, actually, talking about McLeod's daughters and injuries, I made the stupid decision when I was doing the show to have a limp. That might be good for a film for a day, but you tried doing it for 4 years. So I was walking like this for 4 years, and you can imagine the musculoskeletal disorders that I had over that 4 years' time. So it would be very interesting to have someone like Professor Jodi Oakman in ergonomics to have advised me back then. I probably would have avoided a lot of these ailments that I had, which is a bit of a segue because I'd like to introduce you now to the head of ergonomics at La Trobe. She's all about making work healthier, smarter, and also less of a pain, quite literally. She's here to break down what's working, what's not, and also what's next. So please make welcome our keynote speaker, Professor Jodi Oakman. Okay. Yeah. You've got it? Okay. Over to you, Jodi.
Thank you. Right. Thank you, and thank you for the invitation to speak here today. It's really lovely to speak to a room of people in person. It's still a novelty after a few years of not being able to do that. So I'm going to talk today about looking at how and why we need to integrate strategies to manage both MSDs and mental health. I'm going to focus on the MSDs, but actually the real need is to stop addressing those two really complex health disorders separately. So, before I begin, I'd just like to acknowledge the traditional owners of the land and reflect on that really lovely welcome to country that we had. So, So what is the problem? I'm not going to talk about the statistics for WA or Victoria or New South Wales. I'm really going to look at the sort of big picture, the societal burden of musculoskeletal disorders and any other work-related health problem. It's a problem when people can't work, and that matters for all of us, and it's a really expensive problem and impacts our labour supply, which most states are having problems with. And our economy would be much larger if we managed to eliminate musculoskeletal disorders and other health disorders, and our GDP greater. And it's been estimated that the impact of that is equivalent to our agriculture industry. So that's a lot of cost associated with that. The financial cost is one thing, but it's also the personal cost to people when they can't work. So, workplaces hold different meanings for different people. And if we're going to develop effective strategies that support individuals and communities in their work, we need to think about the different contexts when addressing musculoskeletal disorders. We need to identify what the contexts are and what matters in that particular workplace. That is, there is no universal rule book. At times we've tried that, but it doesn't work. So, through considering the past, the present and the future, provides a lens for us to think about where we've been and what's coming, and reflect on what's working and what's not. And this is really important in occupational health and safety and ergonomics practice, because we have to adapt as professionals. We've got a really rapid change of work, pace of work. I don't think anyone here would argue that we don't. So it's somewhat discouraging at times that we haven't managed, despite efforts in MSD prevention, to actually solve that. And I think there's some questions and reflections that we need to have as professionals, me as an academic, about why that's so. Our knowledge around this issue has expanded immensely, but we've known for a long time what the causes are, but we don't really translate that evidence into practice. Regulators have a role here, and so do professionals, to really use evidence in our practice, and when we're not, stop doing that. So I'm going to talk about this evolution of work. And of course, we can't ignore the rapid change of technology and how we need to upskill ourselves in how we're going to use it effectively and stop using it when it doesn't help us in our roles. So let's start by looking at the industrial revolutions, the big picture. So at the macro level, it's helpful to think about the historical changes for workers and workplaces through the lens of these industrial revolutions. The first three are well known to us, and we probably all have images of what that means. And the fourth is just revealing ourselves, and there is a fifth, but I'm not going to go there today because we'll be here all afternoon. The first industrial revolution from the mid-17 to 1800s saw the translation from hand to machine production powered by steam and water. And this revolutionised industries like textiles and iron and contributed to a major societal shift. Images of Dickensian factories and child labour is often what we think of. Unfortunately, some of those situations exist still in some countries. The second revolution from the 1870s to the mid-1900s, to 1914, saw electricity, railroad, telegraphs powering the transformation of work and society further. Henry Ford's first moving assembly line of 1913 is probably the most famous example. If I was in Victoria and I asked people to put their hands up about who'd worked at Ford, I'd get a show of hands. Maybe not so now, but it was offered a great training ground for ergonomists and health and safety professionals, which sadly now that time has ended. The third industrial revolution is much more familiar to us, beginning in the 1950s and considered as the move from mechanical and analogue technology to digital electronics. The internet and rapid advances in information technology have shifted our global economy and the consequences, with significant consequences on how and where we work, and open up many possibilities that weren't there before. The landline made way for the mobile, and we've been glued to our screens ever since. And if that wasn't enough to get your head round, let's think about the fourth industrial revolution that we're in. This concept was introduced by Carl Schwab, the head of the World Economic Forum in 2016. It builds on the developments of the previous and recent digital revolution. Its rapid pace, wide-reaching, and potential to disrupt are really the key characteristics. Automation, data exchange, and systems like AI, the Internet of Things, cloud computing and robotics has had a really rapid and profound transformation on our manufacturing and global business operations, not to mention the way we live, work, and our interactions with each other. So, all this really rapid change in the past 250 years, and in particular the last 15 years, for those of us who are old enough to remember we did have a life without a smartphone and managed to be reasonably successful. Today's focus will be on what are the key role that psychosocial hazards have, and a particular focus on MSDs, but also not forgetting the important role in mental health. So, what are these things called musculoskeletal disorders? Most of us have an understanding of what they are, so I'm not going to dwell on those in particular, but they're a significant problem in workplaces. I don't think anyone can argue that. And we see many different clinical diagnoses, and that's often something in workplaces we can channel down and focus on. They arise from cumulative trauma most of the time, not due to one event. Just as an early word of warning, if anyone's a clinician here, I'm going to say something that may be a little controversial. When we think about diagnoses for MSDs in workplace, it's actually irrelevant. What we need to focus on is actually capacity. That is, what can someone do in their role or at their workplace? So this should be the key focus of how we manage people with musculoskeletal disorders. But importantly, where we should be focusing is much further up on actually undertaking regular hazard surveillance to understand what it is in workplaces which is causing people's pain and discomfort, not something routinely done by many workplaces or done very well. In other words, much too much focus on the end stage, rehab, return to work, managing the claims end, which stage is often too late. We've really got more challenges there. So, don't try and read this. It's it's complex, but what I want you to think about is these are models that we have that show the complex causal nature of musculoskeletal disorders. So they are complex. And one of the problems is we really try and, I'll say, minimise or reduce what causes people's pain and discomfort to a simple cause and effect. And that won't work. If you look up there, there's a range of different models that have been developed or been around for a long time. So we've known about the causal factors, which are both psychosocial factors and physical factors, for a very long time. But our workplace risk management strategies have not kept up with that. Very few, in my opinion, very few workplaces that I've observed have really got a truly comprehensive risk management program which identifies both physical hazards and psychosocial hazards for both MSDs and stress-related mental health. What we tend to do is focus on either MSDs for 1 year and mental health the next year. And when we're only focusing on MSDs, we drop off the focus on psychosocial hazards. These models tell us that that means our MSD prevention will be ineffective to a point. I'll come back to that later on. One of these models is from the mid-90s, the one on the top left from the National Research Council. Anyone who's done some work in this space will have seen this model. It's very well used, it's all over the place. And the interesting thing is it comes from the United States. They have been loath to accept any responsibility that workplaces can cause problems. So the fact that that was developed over 20 years ago is somewhat surprising. And the reason why we keep using it, we say if the states believe this, they may not have translated it effectively into practice, then we need to take notice. The other two are models from my own group at Trobe University. So, what are these things called psychosocial hazards, and how are we going to go about integrating these into workplaces? Physical hazards we're much more comfortable with, and there's a much narrower range of those. So when we look at trying to measure these in workplaces, most workplaces, we've got good guidance which really steps out the physical hazards. And in fact, in our tool that I'm going to talk a little bit about later on, we have 12 measures for that and 47 measures for psychosocial hazards, because there are many more psychosocial hazards given the vast array of different work environments and different contexts that I spoke about further. So how on earth do workplaces go about trying to decide which ones are the right ones to measure? And the answer is, I think, having a go is the first step. Once you start measuring, I'll come back to that. Okay, so there are many, we can think about these as organisational, so around job design, how work is allocated and organised, or these important social context factors, so how people interact at work, the communications with their colleagues and their managers. So, why does musculoskeletal pain matter? And I said before, because it is a significant societal burden. Low back pain is what is the leading cause of a thing called years lost to disability. This is a measure that's done by the Global Burden of Disease Studies every couple of years. And in all conditions, low back pain remains as one of those leading causes. So what does that tell us about where our focus is in terms of prevention? And the reason it's important is one that you all understand, is around this impact on people's ability to work. And I include it here as a reminder because much of our focus in prevention beyond the workplace level, but is around communicable diseases like heart disease, stroke, those sorts of things. But actually, if you want, low back pain is actually up there in terms of consequences for people and their life. The problem is people manage, albeit how effectively, is what I think we should be giving greater thought to. So I'm going to use a well-known company to reflect on what psychosocial hazards mean and what perhaps modern-day warehousing and logistics looks like. Does anyone work at Amazon? No. 7,000 people in Australia work at Amazon, and it's a massive employer worldwide, so about 1.5 million people. Anyone ordered anything from Amazon? Yeah. So it's there. Anything I talk about now is publicly available, which is somewhat alarming, I think. But there are many examples of really poor adverse hazards available in an Amazon case study. When we think about logistics in the past, of which I've spent a bit of time in logistics sheds, they can be dark and cramped, dusty, and but our modern day environments are much more shiny, lots of robotics and other infrastructure. And it's worth thinking about, though, what does that actually mean for a humble logistics worker trying to do their work? So, one of the things that Amazon does to make sure that we get our parcels delivered very quickly is that they use surveillance and they collect data on individual workers' productivity and work rate, task time, how long they're idle, and this leads to poor safety practices and adverse outcomes as people strive to meet their targets. Many groups have tried to improve work environments at Amazon, and this is regularly covered in the global media about what a shoddy employer they are. This does nothing to diminish their success story or us using it, or improve the conditions for workers. A recent study by the University of Illinois in Chicago highlights the physical and mental toll experienced by Amazon workers. 40% of workers felt they couldn't take breaks, over 50% felt they reported being monitored. But I think the most telling thing is over 70% of workers said they'd taken time off without pay because they felt they couldn't go to work. Now, workers only do that when things are really bad, when you don't have the protections, as they don't in many instances, of sick pay or any other sort of leave to take. So, what about the physical versus the psychosocial hazards? Because sometimes in a logistics workplace, we'd be thinking that musculoskeletal disorders would be our main problem. And so this might lead us down a pathway to focus only on the physical hazards. Not true, as we've just seen in the Amazon environment. Now this slide, slightly academic, but I am one. One of the things that we often hear is that, but yes, psychosocial hazards, that they might be relevant, but they're not as important as physical hazards. So we took it upon ourselves at La Trobe to say, well, okay, let's have a look at the literature and have a look at how do they actually compare. We might have been a bit sorry we did that. It's actually proved to be more difficult than we thought. So when we look at this, one of the challenges is that there are so many ways to measure psychosocial hazards. So if this is challenging for me, how challenging is it for people in workplaces to work out what tools to use, and then how to use them, and then what to do about it? So I won't go through the laborious insights of how we did the study. One day you can read the paper when they finally accept it. But the message here is that these lines represent what we call effects, the relative importance of physical versus psychosocial hazards. And perhaps for us, somewhat disappointingly, you can see there that the physical hazards were in fact more important in most of the body areas. And so you go, right, all the naysayers in the room go, well, of course, because it's the physical hazards that are more important. The story's not quite that straightforward. The problem is that when we look at what's published out in the literature, many of the things that we know are really important in terms of psychosocial hazards were not actually measured. Things like the leadership, some of the emotional demands of work, we couldn't actually find had been reported on. So in essence, we're not quite comparing apples with apples. So the message is that there's much more work to do, but it highlights a problem with workplace measurement. So, not to be thwarted, then we have a look at the tools that are available for people like you in the room to actually use to help you develop and implement a really comprehensive risk management process for musculoskeletal disorders. So we were interested in what these tools that were available, tools that were freely available and provided resources to support you in implementing such a program. So again, this paper's out in the public domain. It's freely available, so you can read it if you'd like. And what we found was we were looking for comprehensive, so it needed to address both physical and psychosocial hazards, and then it needed to provide a person using it with sufficient resources to identify what those problems are and then develop effective risk controls. So good quality risk controls and then evaluate whether they work. All the literature across the world, there were 3 tools that did that. The most comprehensive was actually the Affirm toolkit, which I'm going to come to you, and it's one that we developed at Trobe University. So we didn't undertake it to, find our own answer, but we did. But one of the reasons that we developed the toolkit, which I'll come to, was because we knew that there's a lack of such tools available. So, what's happening in the regulatory space? It's always difficult when you're sitting here looking at some of the regulators here, but anyway, I'll have a go. Sally's smiling. It's easy for us to go, well, what's happening or what's changing in terms of the space? And there has been some attempts, and I won't talk about changes over here. I'm going to talk more generally about some of the recent legislative changes to actually address these things called psychosocial hazards in workplaces. So we know that work-related mental health is increasingly being recognised as a work problem. And in some ways, that's been at the expense of musculoskeletal disorders, I might add, because we've shifted the focus to psychosocial hazards and assumed we've only got this relationship to mental health. So one of the things we've seen for white-collar workers is this shift to more hybrid working arrangements and a blurring of work-home interfaces, sometimes good and sometimes not. And many of us probably find ourselves answering calls, texts and other things outside of hours. And if you're like me and we're 3 hours in front, that meant my workday started pretty early this morning. So many governments have put in place legislation to address this right to disconnect. The French were first, as they often are, in 2017, introduced legislation to enable workers to say, I'm not taking calls after 6 o'clock. Other countries have adopted similar things, Belgium, Italy, Argentina, Chile, and quite a big list. So one of the things about the Australian legislation is we don't know how that's translating into practice because it was only introduced in August. But again, it's, I think, just an indication of shift in knowledge or understanding of the importance of that those psychosocial hazards, or that connection and what that can do to our mental health. Because time theft or working outside of hours is actually costs us or our employers stand to gain. And some recent research published in The Conversation found that many of us were at risk of high risk work addiction was the term they used, and that we actually had pretty poor work-life interaction, worse than many other countries, which is the antithesis of what people believe that Australia is, the land of the long weekend. We're long past that, I suggest. So this availability creep is a costly problem to us as workers and our mental health. So this costs about $11,000 per year. And the concern is really about how we integrate this availability with our new working arrangements. And I could spend a whole hour talking about those, but that's not my remit for today. So the question is, will this make a difference? And we can look to Europe to actually some data that they've recently published, which said that when companies had a right to disconnect policy, workers reported higher levels of job satisfaction and reduced health issues. And companies that didn't reported the opposite. But actually the relationship is more complex, because if companies do have the policies, it's likely that they're very enlightened companies and maybe respectful of people's time. And so when we're thinking about these issues, I implore people to think about all the different elements that might impact workers. So I'm going to shift tack a little bit and talk a little bit about these tools. I'm very passionate about translation of research evidence into practice, so that workplaces or professionals within workplaces have the right things to use. The question is whether they use them, and that is something to think about too. But we really, one of the things that we did at Trobe University was really try and address this integration of physical and psychosocial hazards together. And we started doing this, my colleagues started doing this in 2006. So we've been banging the drum for a very long time. But one of the things that anyone that works in a space where you're trying to train to practice, it's a game of patience. And so probably in the last 5 years, we've seen much more engagement from regulators and policymakers about that. But what we knew, both from our experience as practitioners but also as academics, was that the tools available to help workplaces weren't very good or non-existent. So we developed a thing called the Affirm Toolkit to address this significant research to practice gap. And what we wanted to do was to develop something that really fitted with people's mental models of how they undertook risk management in workplaces. So we followed a really risk management approach and based it on a WHO healthy framework model. Because what we wanted to do was to make sure it be used by people in workplaces and not need external consultants to come in to run the particular processes. It addresses both the physical and the psychosocial hazards, I said. And importantly, it addresses hazards and outcomes. And when we think about hazards, we're thinking about these physical hazards, and then trying to encapsulate those vast range of psychosocial hazards that I alluded to before, and how do you do that in workplaces so that it's meaningful? And that's a challenge. I'm not sure we've got it exactly right, but one of the things that if you do anything, and people that engage with their workers and use a participative approach will know that once you start something, workers will talk. And so there's enough there to instigate and really start conversations about how work is done and what's causing the particular problems. And I think whatever your tool you use, if you use that approach, then you'll find out you'll be able to drive your risk management processes using that. I should say we've drawn these measures from well-known frameworks that exist around the world, and we try and do that. We've had to develop some ourselves so that they've been tried and tested in other places. It's a very simple, easy to use system of work, and we get good feedback about people being able to use it, because we've really embedded a whole suite of resources and tools to help people in utilising the process. Right, I don't need to talk about that. It generates reports automatically. I encourage you to go and have a look. There's a website. If you Google a firm, you will find it. And really just get in and have a look. And I say this, I don't mind which tools you use, but I want you to think about whether or not you're doing this sort of thing in your workplaces, because if you effectively want to manage musculoskeletal disorders, you cannot ignore the psychosocial hazards. However difficult people might find in thinking about those, you can already see that you'll miss part of the picture. All right, so these are all just samples of reports that are automatically generated using the toolkit. Right, sorry, that's enough. So, are people actually using it? So we have about 7,000 survey responses. So that means it's being used, and it's being used in about probably well over 80 organisations now. In nearly 300 work groups. So it is now being well utilised and in a whole range of different sectors. So it is not sector specific, just to address what is a very common question that we get. Any organisation or in any sector that has musculoskeletal disorders or stress-related mental health problems can use the toolkit. So, let's think about what we need to do. I think I said if you're not addressing psychosocial hazards in your MSD prevention programs, you will have some success, of course, because there are physical hazards, but you will be limited. And this really highlights the issue here. This graph you can see here is actually using our toolkit data to look at different groups of hazards. So on the left box there, you'll see the physical hazards, and on the right, these are groupings of the psychosocial hazards. And you'll notice that those three lines are closer together on the left than they are on the right. Those are actually, I won't go into latent profile analysis because then you'll all nod off, as I do, it's not my strength. What that means is, the top line is people who are in high hazard jobs. So they're exposed to lots of hazardous hazards, whether they be physical or psychosocial, and the ones at the bottom are the lower hazard profiles. So those ones are closer together, which means in terms of hazards, at the physical level, they're much closer together. For the psychosocial hazards, they're further apart. So if you're thinking about your prevention programs and you want to reduce people in high hazardous working conditions to lower, you're going to get much bigger bang for your buck if you attack the psychosocial hazards than you are for the physical ones. And that's probably because these workplaces that are using the toolkit are large organisations which have really probably focused on the physical hazards a lot because the regulator or whatever has encouraged them to, and traditionally that's where MSD prevention has focused. So if they want to shift the dial, they're going to have to do something about those psychosocial hazards. So I think this is a useful visual to think about where you might get your next shift in your MSD prevention programs. So one of the things that we were interested in was, okay, if you're going to use an approach like a firm, highly participative, comprehensive, what does it do in workplaces? And so we interviewed a bunch of people who had actually used the toolkit to ask them what it was that they, what were the benefits of doing that. And by and large, the most consistent benefit was that it provided a pathway between managers and workers to have a discussion, because you get this very clear reports or identification of hazards and then reports. That gives the two parties something to talk with and about. So even though the problem might have been known, without having something to talk about, it made those conversations more difficult. So it really improved the quality of those conversations. You can read about this in the case studies, but it improved the quality of those conversations. It enabled workers to have a voice, and the processes that we used enabled them to give feedback across the different stages of the toolkit. But there's always a dark side, isn't there? Sometimes it doesn't go well. And if you impose a process on a business that's not ready for it, it's unlikely to be taken well. So those organisations which had used it because someone had said they should, rather than being ready for it, didn't go so well. If there was a lack of commitment, we've heard that many times before, so that you identify what the problem is and then no one does anything about it. I now say that it's better to wait until the organisation is ready. And sometimes when we get a lot of churn in organisations, so you start something and then the person leaves, those organisations had some issues with that. So there's some things to learn about what we can do. All right. I'm an ergonomist, and so systems thinking about the complexity of things is part of what I do. And I don't think everyone in OHS and ergonomics needs to be systems experts, but we do need to understand that things don't happen in isolation. Things happen because something else happened and something else happened. And so when we get a regulatory change, sometimes that trickles down, but sometimes that takes a while. Sometimes it has consequences that we didn't imagine. But those levers of what happens at our workplace level, labour market supply, etc., can be a long way to what's happening down at ground level. And some of our OHS processes forget about those influences. And so these are things that we really need to take into account. MSDs and stress-related mental health, both with psychosocial hazards in their etiology, are complex. And they're caused by a wide range of different factors, and it's really important that we think about that in our risk management processes. So, as we can see today on our brief journey through the 4 industrial revolutions, technology and work practices, there's been changes beyond, beyond measure in many ways. But psychosocial hazards are not new. They've been around for a very long time. The increase in technology and automation has reduced some of the physical loads, but created new challenges. And our Amazon example gives us some insights into that. Some jobs have not changed very much, but an awareness of the key role of psychosocial hazards that play in MSDs has grown, so it's not all gloom and doom. But our prevention strategies must keep track with those changes in knowledge and using the evidence that we have available to us. So I conclude my talk today with a very simple call to action. Everyone engaged in prevention, including regulators, ergonomists, health and safety professionals, academics, needs to use evidence to drive their prevention programs. And we need to stop doing what doesn't work and what we know doesn't work. But I look forward to hearing your ideas about what we can tackle together, and there'll be opportunities for that throughout the day. Thank you very much.
Thank you. Thanks, Jodi. Thanks for that. That was so insightful.
Some really interesting things for me, for someone who has actually experienced chronic back pain. I actually read a book a while ago called Healing Back Pain, which was a bit of a neurological, neuroscience sort of perspective on the physical manifestation of pain from repressed emotions. So a few questions have come up in that psychosocial space. You may have already answered them, but I'll touch on them. One is, what is the likelihood that some musculoskeletal disorders are the physical manifestation of some of these chronic psychosocial hazards?
Quite a lot.
Quite a lot.
Yeah. So I think that the really important thing is that terminology matters, but importantly, psychosocial hazards cause a stress response, and I didn't, go into that in detail. My postgrad students get 2 or 3 hours just on that, but it causes a stress response, which is a physiological change. And if it was ethical at all, and we took blood samples of people being exposed to psychosocial hazards, we would see a change in those stress hormones. So it's not in people's head, despite the fact that some of our perhaps less enlightened managers might think it's just, they're imagining it. It's not. We would actually be able to measure that.
Is this a new space?
No.
No? This has been around for a while?
Yeah. This is not new. I mean, the models that I put up there, one of them from the 90s, and I could probably dig out earlier than that too. But this is not new. We've known that exposure to psychosocial hazards causes a stress response forever. But translating that into the work environment and thinking about those workplace exposures has been, I guess, had some resistance.
Yeah, that's the point. Is it a tough sell when you're starting to combine sort of neurological and neuroscience studies with more sort of clinical data? People buy into it quickly, or is it a harder sell?
No, I'm not a patient person. When I was meeting with the regulators in 2010, and it was a hard sell to get the not this state, to actually get them think about how you're actually going to put a provisional improvement notice on a psychosocial hazards. I get why it was difficult, but I thought, we've sorted this in a couple of years. To 2024. We're good friends, I might add, WorkSafe Victoria and I, so it's all fine. But it's hard because you've got to convince, you've got to have processes and regulatory processes in place, but you've also got to get everyone here in the room, but importantly you're here, your managers, your people you report to on board, and they've got to understand it and then want to do something about it. So it's not quick.
No, I can imagine. We have one more question here. Are there any studies on how big of a role pre-employment and ongoing fitness for work medicals play in preventing MSD injuries?
I may be thrown out of the room. Not a solution.
No?
Might be good for something, but not for that.
Okay.
Yeah.
Well, let's put our hands together for Professor Jodi Oakman. Thank you so much. That was very insightful.